Usually when we talk about modern medicine, there's this underlying expectation of precision. It feels sort of like engineering.
Oh, for sure. Very mechanical.
Right. Like you break your arm, you go to the ER, and the X-ray shows that jagged white line on a black screen, and the doctor just points to it. It's broken or it's not broken.
Yeah, it's entirely binary.
No.
And, I mean, the human brain really craves that kind of visual categorization, because it implies that there is a clear, linear path to a solution. Like if we can see the break, well, we can cast the break.
Exactly. But then you step out of the realm of a simple fracture and into the world of navigating a massive healthcare system during a life-altering illness, like cancer.
Right. And suddenly all that precision just vanishes.
It really does. You aren't just fighting a disease in your body anymore. You're fighting this diagnostic and bureaucratic landscape that is just overwhelmingly murky.
Yeah, you're dealing with, insurance portals and out-of-network denials, referral loops.
Oh, the referral loops and the medical jargon. That might as well literally be a foreign language.
Absolutely.
Well, welcome to this deep dive. Today, we are looking at a stack of sources that essentially form the internal blueprint, the operational playbook, really, for a fascinating startup based in Tampa Bay called SGB2B.
It's a really unique set of documents.
It is. And our mission today, for you listening, is to explore exactly how this startup is attempting to bridge massive systemic gaps in our healthcare infrastructure. And they're doing it by focusing entirely on culturally intelligent, non-clinical support.
Right.
Okay, let's unpack this. Because reading through this blueprint, it becomes very clear, like immediately, that SGB2B is not a medical clinic.
No, not at all. And that is actually the foundational pillar of their entire model. SGB2B explicitly, and I mean strictly, separates clinical treatment from community-based care.
Meaning they aren't playing doctor.
Exactly. They do not diagnose diseases. They don't administer medical treatments. Instead, their operations are hyper-focused on these sociocultural, emotional, and administrative disparities faced specifically by Black, Brown, and Hispanic families within the healthcare system.
So it's a parallel system, essentially.
Yeah, the strategy is to build a robust ecosystem of support that runs parallel to the actual medical intervention. So the hospital handles the tumor, right? And SGB2B handles the devastating administrative and emotional weight that basically arrives in the exact same envelope as the diagnosis.
Man, that's such a good way to put it. It's about filling the void between the sterile doctor's office and the reality of the patient's living room.
Right.
But before we get into the actual services they provide, because they are genuinely innovative, we really have to understand who built this architecture and why.
Because the model is so specific.
Yeah. When a service model is this culturally specific, it is almost always a direct reflection of the architect herself.
Oh, you see this immediately when looking at the founder's background in these sources.
Yeah.
The driving force behind SGB2B is a Black woman who is actually a survivor herself.
Right?
She's personally endured 6 surgeries. So, this entire operational blueprint isn't born from some abstract academic theory. It's literally born from the recovery room.
Which gives it so much weight. And she has roots in Flint, Michigan, right? But she specifically credits her support system down in Tampa, a network she actually refers to as her soul tribe, for helping her survive those health crises.
Yeah, the soul tribe. And what really caught my attention isn't just that she's a survivor. It's the dual perspective she brings to the table.
Oh, the business side.
Exactly. The sources note she officially transitioned into formal community health worker, or CHW work, fairly recently in 2026. But she spent a decade prior to that working in the insurance and healthcare business sectors.
So she's literally been on both sides of the clipboard.
Both sides. Add to that the fact that she witnessed an end-of-life transition by request and had her own deeply impactful care experience at St. Joseph's Women's Hospital in Tampa.
It's just a wildly comprehensive background. I think of it like this. She is basically a bilingual guide in a highly dangerous, incredibly confusing foreign country.
Oh, that's a great analogy.
Right. Because on one hand, she speaks the cold, heavily coded language of the healthcare system. The prior authorizations, the deductibles, the liability waivers.
Stuff that makes your eyes glaze over.
Exactly. But on the other hand, she speaks the warm, intimate, cultural language of the community. In fact, the intended voice of the startup is described in the documents as an auntie with the business.
Love that phrase, auntie with a business.
It's so evocative. An auntie is someone who loves you enough to bring you soup, but is, stern enough to make sure you fill out your paperwork correctly.
She's not going to let you slack on the forms.
No. And the operational documents also use the term faith light, which I found super interesting. They offer deep comfort and acknowledge the profound spiritual reality of a health crisis, but without imposing heavy religious doctrine.
Right, because they recognize that in many Black and brown communities, faith is deeply intertwined with healing, but they need to keep the support universally accessible.
Exactly.
But, this raises an important question, though. Why is an ante with a business model functionally necessary in modern multi-billion-dollar healthcare?
Right. Why can't the hospital just do it?
Well, to answer that, we have to look at the exact disparities SGBDB is targeting in the sources. The data they're operating from shows that Black and brown women experience significantly higher mortality rates and consistently face later-stage diagnoses compared to other demographics.
It's bleak.
It is. Concurrently, Hispanic families are confronting severe language and access barriers that literally prevent them from engaging with preventative care or understanding early treatment options.
And we should clarify how they view that data, right?
Yes, we need to be crystal clear on how SGB2B views this. They operate on the absolute principle that these statistics are the result of systemic, historical inequities in how care is delivered and communicated.
Right, these numbers do not reflect personal failures on the part of the patients.
Not at all. There is no assignment of personal blame here.
Yeah, they're looking at the machinery of the system, observing the systemic outcomes, and basically saying, this is where the engine is breaking down for these specific groups. There's no sensationalizing of the trauma. It's an impartial, operational attempt to fix a broken user manual.
A broken user manual, exactly.
And understanding that the sheer bureaucracy of the system is the primary obstacle, well, that naturally shifts our focus to how SGB2B directly tackles that confusion. Because the first hurdle a family hits isn't always the chemotherapy itself, right? It's the sheer volume of paperwork and terminology.
Oh, it's the absolute mountain of unfamiliar vocabulary that arrives on day one.
Which brings us to a specific SGB2B initiative called the Fine Print of the C Diagnosis. And the premise here is just heartbreakingly real.
It really is.
The documents point out a generational tragedy. Many families know that cancer has touched their lineage. Like, they know their grandmother had it, they know their mother had it. The awareness of the disease is ever present.
But the literacy isn't.
Exactly. They were never actually taught the modern oncology terminology. The historical knowledge of the pain is there, but the literacy to fight it in a modern hospital setting simply isn't.
And that gap in literacy is exactly where the fine print program is deployed. Its entire function is to break down terrifying medical terms into plain, actionable language.
Like what kind of terms?
Well, when an oncologist walks into a room and rapidly uses words like stage, grade, tumor type, hormone status, or triple negative, they're just using standard classifiers, right?
Just doing their job.
Right. But for a terrified patient, that jargon creates an immediate wall of cognitive overload. If you don't know what triple negative means, you cannot ask informed questions about your treatment options.
You're just paralyzed.
Exactly. So SGB2B acts as the translator in the room, or, right after the appointment, so the family can actually process what was just said. But, as we noted earlier, there's a strict operational boundary here.
Right. No medical advice.
Right. SGB2B provides non-clinical guidance. They explain the vocabulary. They do not suggest which chemotherapy drug to take.
Here's where it gets really interesting, though. Because it's not just medical jargon they're translating, it is the financial and insurance maze.
Oh, yeah.
This is where those 10 years in the insurance industry turn into a literal functional superpower for the founder. SGB2B helps families navigate the dreaded in-network versus out-of-network barriers, the referral delays, the general panic that sets in when the bills start arriving.
It's a huge part of the puzzle.
But wait, I have to challenge this model a bit here based on what we're reading.
Yeah.
If SGB2B is explicitly not giving legal advice and they are strictly avoiding any medical advice, how much practical help can they actually offer a family that is drowning in hospital bills?
That's a fair question.
Because translating a piece of paper doesn't magically make a $50,000 balance disappear. Doesn't this non-clinical boundary severely limit their actual impact?
Well, if they were only intervening after the debt was finalized, yes, it absolutely would. But the model is built around preventing what the industry calls financial toxicity.
Financial toxicity.
Yeah, this concept is heavily prominent throughout their blueprint. Financial toxicity is the devastating long-term economic side effect of medical treatment. The bankruptcies, the lost homes, the depleted savings.
Wow.
SGB2B's intervention happens early. By translating the reality of insurance barriers on day one, they stop the family from making expensive, irreversible mistakes.
Okay, give me an example of how that works in practice.
Okay, Imagine a caregiver is completely overwhelmed and just wants their mother to get a scan immediately, right?
It's understandable.
Completely. So they might unknowingly agree to go to an out-of-network imaging center because it has an earlier appointment, not realizing it will result in a $10,000 out-of-pocket charge that their insurance will completely refuse to cover.
Ouch.
Yeah. So SGB2B comes in and stabilizes that panicked caregiver, explains exactly what in-network means for their specific policy, maps out the correct referral process, and prevents that catastrophic bill from ever existing in the first place.
That is massive.
It is. Stabilizing the administrative chaos is a vital preventative intervention.
That makes total sense. It's less like walking through a minefield and more like trying to represent yourself in a highly complex foreign court of law where you don't even speak the language.
Exactly.
The ante with a business is the translator who stops you from accidentally signing away your life savings just because you were intimidated by the judge and didn't understand the contract.
That is a perfect way to conceptualize it. The administrative stabilization basically creates the breathing room needed for the patient to actually focus on staying alive.
Right, but keeping a family out of medical bankruptcy is really only half the battle. Once the paperwork is sorted, you still have a human being who has to endure the brutal physical and emotional toll of the illness.
Yeah, the actual lived experience of it.
Right. And this is where we see the operational model transition from administrative defense to deeply personal physical care. Let's look at two specific community-level programs in the sources: Crowned Again and Sisters Feeding Sisters.
These programs are where the concept of cultural intelligence moves from theory into physical practice.
Yeah, let's start with Crowned Again. This is a program offering dignity-centered support for hair loss during treatment. And the foundation of this initiative specifically highlights the need to honor the immense emotional and cultural weight of losing one's crown within Black and brown communities.
It's such a profound thing.
It is. It's not just about the biological reality of losing hair. It is a profound loss of identity. You know, in psychology, there's a concept called enclothed cognition.
Oh, right.
It's the proven idea that what you wear and how you physically present yourself directly alters your psychological state and your resilience.
It changes how you feel on a biological level.
Exactly. And I would argue that healing requires the mind just as much as the body. If a patient feels stripped of their identity, if they look in the mirror and only see a victim of a disease, their psychological resilience just plummets.
Yeah.
So preserving a woman's dignity when her body feels like a war zone isn't a cosmetic luxury. It is an essential component of survival.
I couldn't agree more. The preservation of identity is a massive factor in clinical outcomes, which is why treating the whole person culturally is so vital.
Yeah.
And this seamlessly bridges into their other major physical initiative, Sisters Feeding Sisters. We constantly hear doctors tell recovering patients they need to, eat well or stay nourished.
Oh, yeah. Make sure you eat a balanced diet.
Right, which is so vague.
Yeah.
But SGB2B doesn't just hand out a pamphlet on nutrition. They physically subcontract with local caterers and restaurants to provide the meals.
Real food.
Real food.
Yeah.
The blueprint specifically names Chef Brown's Catering and JJ's Eatery as active partners, and they're even in the process of developing a signature soup line.
Now, what's fascinating here to me isn't just the food itself, it is the business structure behind it. Looking at the NAICS codes, the standard classification codes the government uses to define what a business actually does. SGB2B lists 6242 for community food services and 72232 for caterers, right alongside their traditional family services codes.
What's fascinating here is that the inclusion of those specific business codes is quietly radical.
How so?
It proves that SGB2B is legally and structurally defining local economic empowerment as a healthcare initiative.
Oh, wow.
Yeah, they are not buying bulk generic hospital food. They are hiring local neighborhood chefs. Culturally familiar meals, food that actually tastes like home, are treated as structural components of caregiver stabilization.
That is brilliant. It creates a closed-loop microeconomy. You support a sick community member by paying a healthy community member to cook for them.
Exactly.
You keep the healthcare dollar circulating within the neighborhood rather than sending it to a massive out-of-state food service conglomerate. But to execute that, to know exactly which local caterers to hire and how to address these highly specific cultural nuances, you can't just drop this business model into any random city. It requires a massive amount of local integration.
Just so much of local knowledge.
Yeah, and when you look at where they are doing this, Tampa Bay, the complexity of that integration becomes incredibly obvious.
Right. Tampa Bay is not just a backdrop here. It is a crucial defining variable in how this model operates. The operational documents detail a launch strategy that is hyper-localized to the real-world demographics of that specific region.
Yeah, I was looking at the linguistic diversity SGB2B is set up to support, and it is a massive undertaking. We are not just talking about offering a Spanish translation of a flyer.
No, not all.
They are providing culturally fluent support in English, Haitian Creole, and Spanish. They are specifically reaching out to a complex mosaic of families: Haitian, Dominican, Puerto Rican, Cuban, Mexican, and Central American. The nuances between those cultures are vast.
They are vast, and the blueprint insists on reflecting the actual clinical reality of Tampa, explicitly demanding the avoidance of flat stereotypes or cultural erasure.
Right.
Think about the friction in a typical hospital room today. SGB2B's network interacts with a rich, highly complex mix of practitioners. A single patient's care team might consist of an Indian charge nurse, a Filipino floor nurse, a white attending physician, a Black oncologist, and a Hispanic medical assistant.
All in the same room. And sitting in the bed is a Haitian patient who only speaks Creole, surrounded by a family terrified of the medical bill.
Precisely. That room contains 5 or 6 different cultural backgrounds, different baseline assumptions about authority and medicine, and potential language barriers.
There's a lot to navigate.
It is. SGB2B is building a model that sits right in the middle of that friction, acknowledging and navigating that exact mix so the patient doesn't get lost in the translation.
So, with all these incredibly ambitious programs, the multilingual translation, the catering partnerships, the health literacy deep dives, where does SGB2B actually stand right now as a functioning business?
Well, the documents show they are currently operating under a limited enrollment status.
Okay.
They are deliberately capping their launch just 25 clients while they complete their full AHCA enrollment. That's the Agency for Healthcare Administration in Florida.
25 clients. That's really small for a startup.
It is, but if we connect this to the bigger picture of startup culture, it is a massive indicator of operational integrity.
Okay, I see what you mean.
Yeah, in the tech world, the mantra is always move fast and break things.
Right.
Scale at all costs.
Right, but you can't do that here.
Exactly. In the healthcare sector, if you break things, you break human beings. Capping the client base at 25 is framed within their strategy as a strict commitment to transparency. It ensures that the auntie with a business model doesn't overpromise and underdeliver.
They need to prove it works first.
Right. They're ensuring they can safely, legally, and ethically manage the immense weight of these 25 families before trying to manage 250.
It's slow, intentional, deeply rooted growth. And even with a cap of just 25 families to start, they're already weaving a massive web of community integration.
No, the partnership list is extensive.
It really is. They are targeting partnerships across the entire spectrum of the city. They're aiming at major institutional players like Moffitt Cancer Center and Baycare. But they're equally focused on grassroots entities, local primary care clinics, neighborhood churches, Hispanic serving organizations, and senior centers.
They have to be everywhere.
Right. They are trying to embed themselves into the very fabric of the city's daily life.
Because that is the only way a non-clinical bridge model functions. It has to earn the trust of the massive, intimidating hospital systems, and it has to hold the trust of the local church pastors. It has to stand firmly with one foot in both worlds.
So what does this all mean? When we step back from the individual programs and look at the entire SGB2B blueprint, we are looking at a profound paradigm shift in how we define care.
We really are.
They're taking elements that the traditional medical industry typically dismisses as soft skills or optional extras, cultural fluency, the plain language translation of a terrifying diagnosis, the dignity of preserving a woman's appearance, a bowl of familiar soup made by a chef from your own neighborhood.
Things that get overlooked.
Exactly. And they're treating them as foundational, non-clinical pillars of surviving a health crisis.
And as we've seen throughout their operational strategy, this model maintains a strict, objective focus on closing gaps in a highly complex ecosystem.
Yes.
They are looking at systemic outcomes, language barriers, and bureaucratic failures impartially. They are executing a purely functional, highly empathetic intervention designed to make a massive, broken machine work better for the exact people it has historically served the least.
It's entirely about rewriting the user manual so that the people actually using the machine can read it.
Which leaves us with a fascinating, almost provocative thought to ponder as we wrap up today.
Oh, what's that?
Well, if a highly localized, hyper-specific model like SGB2B, one that relies heavily on neighborhood caterers, plain language translation, and a strict, unyielding separation of clinical treatment from community care, if that proves undeniably successful for these initial 25 families in Tampa.
Yeah.
Could the future of navigating massive, impersonal, nationwide healthcare systems actually rely on an army of community-funded aunties with a business?
Wow. Imagine that reality. Instead of relying on a colder, more automated algorithmic machine to fix the bureaucracy, the ultimate solution might just be a warmer, deeply human guide.
Exactly.
A bilingual guide walking with you through a dangerous country, holding your hand, and making sure you understand the fine print before you sign. Thank you for joining us on this deep dive into these sources. Keep exploring the systems around you, keep asking questions, and we will catch you next time.